All right, welcome. If you're in medicine, you're going to see CPAP a lot. It stands for Continuous Positive Airway Pressure, and it is everywhere, from the ICU to the clinic. But here's the thing. Mastering CPAP isn't just about tweaking the numbers on the box. It's really about mastering the patient. And today, we're going to get right into how you do that.
So let's start with a kind of weird idea. What if the cure for gasping for air was just more air? I know, it sounds completely backwards, right? Someone can't breathe, so we're going to force air into them? But that's the beautiful, simple genius behind CPAP. It's basically a splint made of air for the airway. A really simple concept that honestly changes everything.
Okay, so here's what we're going to cover. First, the basics. What even is CPAP and how does it affect physiology? Then we'll get into the clinical stuff, when to use it, and maybe more importantly, when to absolutely not use it. And then we're going to tackle a really tricky problem. What do you do when the machine says everything's fine, but your patient is still dead tired? We'll look at some real data and then pull it all together with some key takeaways you can actually use.
All right, let's dive in. First things first, what exactly are we talking about when we say CPAP? To really get the finer points of managing it, we've got to be super clear on what it is and, just as important, what it isn't.
You know, the name actually tells you everything you need to know. Continuous. That means it's one steady, constant pressure. It doesn't matter if you're breathing in or breathing out, the pressure is the same. And positive. That means the pressure is always higher than the air in the room. It's literally acting like a little scaffold, just propping that airway open.
Okay, and this is where people get tripped up all the time. CPAP versus BiPAP. Think of it like this. CPAP is like a car with one gear. It's just one constant pressure, period. BiPAP, on the other hand, has two gears. It gives you a higher pressure when you breathe in and a lower pressure when you breathe out. So the key takeaway is this. CPAP is all about keeping the airway open, patency. BiPAP does that too, but it also gives you an extra push, some real ventilatory support to help move air. It's a super important difference.
So, we're pushing this constant positive pressure into someone. What's actually happening inside their lungs? Well, it sets off this whole physiological chain reaction that's actually pretty amazing when you think about it.
I want you to picture the upper airway as like a floppy straw. In obstructive sleep apnea, when you're asleep, the muscles get all relaxed, and that straw just collapses. Bam! Airflow is cut off. This is a perfect example of what's called the Stirling resistor principle. You've got a collapsible part that's limiting everything downstream. CPAP is the beautifully simple solution. It just increases the pressure inside that floppy straw, basically stenting it open from the inside out.
And that one simple action creates this massive domino effect in the lungs. That constant pressure, that's basically PEEP, positive and expiratory pressure. What it does is keep all those tiny little air sacs, the alveoli, from collapsing at the end of every breath. This means you have more lung surface area ready to go, which increases your functional residual capacity. It helps balance out ventilation and perfusion. That's your VQ matching. And the end result of all of this? Better oxygenation. Simple as that.
Okay, so the physiology is cool, for sure. But in the real world, it all comes down to clinical judgment, right? Knowing when to reach for CPAP is one thing. Knowing when to keep it on the shelf is just as critical, if not more so.
So, here are the big ones, the greatest hits for CPAP indications. First, obstructive sleep apnea. That's the classic, the one everyone thinks of. Then, in the ED or ICU, you'll see it all the time for acute cardiogenic pulmonary edema. It's amazing for reducing preload in the work of breathing. Head down to the NICU, and it's a lifesaver for newborns in respiratory distress. And back on the floors, it's a go-to for supporting patients with hypoxic respiratory failure, sometimes even helping you avoid reintubating someone.
And now for the big red flags, the do not pass go. This is all about keeping your patient safe. Rule number 1, and this is non-negotiable, your patient has to be breathing on their own. CPAP does not breathe for them. So if they're coding, if their blood pressure's in the tank, if they can't protect their own airway, CPAP is off the table. And of course, common sense things like major facial trauma or recent GI surgery where you don't want to be pushing pressure, definitely a no-go.
Okay, so picture this. You've done everything right. You picked the right patient, you've got them on CPAP, you check the machine, and the numbers look perfect. Their breathing events are gone. Mission accomplished, right? Well, this is where things get complicated.
Because this is one of the most frustrating things you'll encounter. You fix the breathing problem, the apneas are gone, but your patient comes back and tells you, "Doc, I'm still exhausted." That main symptom, the thing that's wrecking their life, is still there.
So, what gives?
This has a name. It's called residual excessive daytime sleepiness, or just residual EDS. And let's be clear, this isn't because the machine is broken. This is a really complex issue, where the patient is still incredibly sleepy even though their AHI, the apnea-hypopnea index, looks great on paper. You fix the breathing, but for some reason their brain just isn't getting the restorative sleep it needs. So the big question is, who gets this?
Okay, so let's shift gears from the concept and look at some hard data. Just how big of a problem is this? And can we actually predict which of our patients are going to struggle with it? We're going to dig into a pretty big real-world study that gives us some surprisingly clear answers.
So this data comes from the Danish National Patient Registry. We're talking over 1,100 patients. And what the researchers did was track their sleepiness using the Epworth Sleepiness Scale, or ESS, before they started CPAP and then again at follow-up. What's so great about this is that it's not some perfect controlled lab study. This is messy, real-world data, which is awesome because it tells us what's actually happening out there with real patients.
And the good news is, right off the bat, CPAP is rock star. Overall, it's super effective. Before treatment, you had 41% of patients with sleepiness. After CPAP, that number drops all the way down to 16%. I mean, for most people, this is truly a life-changing treatment. But there's a catch.
And here is the but. This is the key finding. When the researchers looked only at the patients who started out with severe sleepiness, nearly 40% of them were still sleepy after treatment. Think about that. Almost 4 out of 10 of our most severely affected patients are not getting the full benefit they desperately need.
And if you take away only one thing from the data, let it be this. After they crunched all the numbers and controlled for everything else, the single biggest predictor of having leftover sleepiness was how sleepy you were to begin with. A patient starting with severe sleepiness was 13 times more likely to still be sleepy after treatment compared to someone who wasn't sleepy at all. 13 times! That is a massive signal. So what about adherence? I mean, we're always hammering this point home with patients. You gotta use the machine. And the data backs us up. It definitely matters. Patients who were adherent were about 38% less likely to have that residual sleepiness. That's a big deal. But when you compare that to the 13 times risk from baseline sleepiness, you start to see that adherence is part of the puzzle. But it's not the whole picture, not even close.
Okay, so we've got all this great data. Now what? How do we turn this into something you can actually use on a busy Tuesday morning in the clinic? Let's boil it all down into a super practical checklist.
Here it is, your 4-step plan. Step 1. Get a baseline Epworth score on every single patient. Don't just see it as a number for the chart. It's your risk stratification tool. Step 2. Use that score to set realistic expectations. To your really sleepy patients, you need to say, look, we're going to fix your breathing, but the sleepiness might stick around for a bit, and we'll have to work on that. Step 3. Keep an eye on adherence. It's important, it helps, but don't let it be the only thing you focus on. And finally, step 4. If the machine's data looks good, if their AHI is low, but the patient is still wiped out, you've got to play detective. That's when you start looking for other things, like depression, which the study also flagged as a major player.
And so, I want to leave you with this final thought. It is so easy to just look at the machine's download, see a low AHI, and check the win box. But our job isn't just to fix a number on a screen. Our job is to give people their lives back, their energy, their ability to think clearly, to enjoy their families. And what this data really tells us is that for a big chunk of our patients, doing that means we have to look past the machine and focus on treating the whole person.